This mini lecture is going to be on cataracts, and cataracts are very common in primary care. And these are something that you're going to be picking up on a little bit more than you would see glaucoma or even macular degeneration. And although you wouldn't be treating cataracts, it's important that you do understand a little bit about them so you have the ability to at least recognize them based on the symptoms and the signs that the patients give you, and also then make a decision on how you're going to refer the patient for these, because these are really very concerning because they're the leading cause of blindness worldwide. And even in many third world countries, more than 50% of all people age 65 to 75 do have cataracts. And 92% of all these patients older than 75 do have some type of opacity in the lenses. So cataracts do impair the vision due to loss of the transparency of the lens, and there's progressive and painless clouding of the natural internal lens of the eye. So it can block light, making it difficult to see. And then there's blindness, which can also occur. So the lens inside the eye works much like a camera lens, and it focuses light onto the retina for clear vision and adjust the eye's focus. So it lets us see things clearly, both up and close and far away. So some of the causes are that, there's a buildup of protein in the lens, and the lens inside the eye works much like a camera lens. It focuses light on the retina for clear vision. It adjusts the eye's focus, letting you see things clearly, both up close and far away. And it's made mostly of water and protein, and the protein is arranged in a precise way that keeps the lens clear and lets the light pass through it. But as we age, some of that protein may clump together and start to cloud a small area of the lens, which then is called the cataract. And over time, it could grow larger and it could cloud more of the lens, making it harder to see. So no one really knows for sure why the eye's lens changes as we age, forming cataracts, but they do think there are some risk factors that are involved with it. There's age-related cataracts, which are obviously from the result of aging. And there are also congenital cataracts, which some babies are sometimes born with this as a result of an infection or injury or some type of poor development, as well as development which can occur just generally in childhood. The secondary cataracts develop as a result of possible diabetes, UV light radiation, and even from the use of diuretics and corticosteroids. But probably the majority of it is usually related to the diabetes, the radiation, and the UV lights. And then there's the traumatic ones, which are formed after an injury to the eyes. So some of the risk factors that are seen with cataracts, besides advancing age, is that, UV light radiation from sunlight, diabetes, hypertension, cigarette smoking, um, obesity. There could be prolonged use of corticosteroid medications, statin medications, previous eye surgeries or eye injuries, sometimes hormone replacement surgery. Hormone replacement therapy, as well as alcohol consumption. And, you're talking heavy. Some of the signs and symptoms that patients will complain of include the foggy vision. They feel like everything is very clouded. It's blurry. There's a lot of filminess over their eye. They may complain of being nearsighted, which will progress. They'll tell you that they're seeing colors differently than they used to. They may see, greens and blues and many different colors. Night problems when driving because of the glare of the lights. It's almost like a halo around the lights, or else like stars around the lights. They may get glares during the day, and also sudden changes in their prescriptions. And this has seemed to be what the biggest problem is that they will complain that, I went for 2-3 years, I've never had my prescription changed, and now all of a sudden their vision has significantly changed. And that's kind of a warning sign that maybe something could be going on. And they also may see some double vision. So this is just a picture of cataract that you can see. So you can see the filminess and the cloudiness over the eye. And you can see in the right-sided picture where the lens actually gets clouded. And you can see how the as the light progresses through, the lens starts to, the light starts to decrease. So when you're trying to get a history on these patients, it's really important that you ask them about their visual status. So, are you seeing lights around, like halos around headlights at night? Are you seeing like stars around those headlights? Are you noticing visible differences in your vision? Are you noticing that you're seeing double, or that you're having so many difficulties seeing now? And is it happening in only one eye? Is it happening in both eyes? Are you a smoker? This is part of getting your review of systems. Are you a smoker? Do you use alcohol? Have you been exposed to air pollution? What is the history of any ocular injuries that you've had, diseases, any treatments, any surgeries? And then getting their full medical history. So it's really important when you're getting that history of present illness as well as the review of systems. And then during their physical exam, it's always really important to go ahead and get their visual acuity. That's really important with anything that you do in regards to the eye. So that's should be your top priority, is the visual acuity. And when you're doing visual acuity, you should do it at both near and at a distance. The When you're using the ophthalmoscope lens, you want to set that lens to 0 and stand about 12 inches from the patient, and you should get a bright red reflex seen through the normal eye. So if a cataract formation is clearly seen, it's going to be in the disruption of the red reflex. The fundus should also be examined for any retinal abnormalities, particularly macular degeneration, which is manifested by some type of hemorrhage or scarring, and this can cause loss of vision symptomatically. So you want to be looking at vision, you want to be looking at pupillary response, you want to be checking the fundus, the red reflex, and doing visual fields for confrontation. As far as medical care, you really are not going to get involved in this other than referring out to ophthalmology, and then they're going to be making the decision on what they want to do based on what they see. They may just do some waiting and, see how the patient does in a few months. It's possible that they'll go ahead and do cataract surgery by doing an intraocular lens implant. They may do one eye and then 1 month later do the next eye if they have to do that. So that decision will be made by the ophthalmologist, and you really don't have to get involved in that.